Thanks very much for inviting me. I want to thank Chris and John for lowering the tone because I'm going to continue the trend and lower it further. And thank you for Michael and John for inviting me. So, death, dying and the difficult conversation. This actually stems out of a communication workshop that Alan Giles and myself developed and have run initially in the southwest of Sydney, but all over. And we've been doing that for a number of years. And as you can see, we're doing some non-verbal communication in these two photos. So this is it's a day-long workshop designed for 24 people. I think we have 300 people in the room, and I'm going to try and deliver it in 20 minutes. So it'll be an interesting journey. Difficult conversations. We have lots of difficult conversations in the emergency department. And, you know, this may be one of the difficult conversations you're going to have with your staff. And interestingly, if you want to design a pathway or protocol around this, you can send it to Michael, and Michael will organise the pathway and disseminate it, and we can all see what the uptake's like. But why do you have difficult conversations in the emergency department? And I think it's really easy for us to get frustrated with patients and with relatives because, you know, you're talking to them, but in the back of your mind, you know that there's 50 people waiting to be seen. You know that there's someone having a seizure in the waiting room. You know that there's, you know, junior medical officers and med students roaming throughout your department, completely unsupervised and unchecked. And you know that your bladder's screaming out to be emptied. And you just want to end the conversation and get on with all the jobs you want to do. But we forget that we see people at their lowest ebb. And this is the lowest they're ever going to be. They're in pain, they're confused, they're anxious, they're scared, and they have me trying to convey a really, really complex idea to them in a very short space of time. And, you know, sometimes they're intoxicated and sometimes they have all of those things on that list all at the same time. How can you do that? How can you do a good conversation? And it becomes really, really difficult. So that's what we're going to try and explore in this very brief space of time. And we're going to use Michael as a guinea pig. Michael didn't have any idea I was going to ask him today, did you, Michael? So this is all going to be very interesting. So what I want you to do to start with is just think back over the last couple of weeks and what are some of the difficult conversations you've had in the last couple of weeks. Just shout them out. What sort of conversations? No one? No one's had a difficult conversation? I've had like 8 difficult conversations and that's just at home.
My wife never answers my phone.
Yeah, that's a counselling service that I offer later on. Yeah. Sorry, you had your hand up? No? So, I mean, that's a great example of a conversation that potentially could have been done better. And usually those conversations are not done well, not because the doctor doesn't want to do them well, but because of all these other competing things. So I think that would set in this sort of... I've separated into what I think are the hardest conversations, and breaking bad news is a really difficult conversation. We do it, you know, multiple times in a shift. And breaking bad news well is a really difficult skill. Another thing I think that is really difficult is the decision-making conversation. You know, so the decision to get thrombolysis could be a decision. You know, decision-making, shared decision-making is a great thing, isn't it? I mean, I love shared decision-making. That's sort of not passing the buck, but sharing the buck with the patient and allowing the patient to decide, because in the end it's the patient's life that's going to be affected by it. My dad's a GP, and he often says that he never shared a decision with a patient, and the patients always said, "Well, whatever you think, doc." And I think the difference is TV. You know, so in Dad's day, the only medical drama on TV was Quincy MD, and you know, he ate sandwiches during an autopsy and broke down the door and occasionally solved a mystery. Whereas, you know, we're exposed to ER and Grey's Anatomy and all of these other medical shows, and there's, you know, beautiful people in pristine scrubs, and you know, they've got great hair, and they're, you know, off having sex every 20 minutes, and where did I go wrong? That's not my life. And the scrubs, I mean, I get to the end of my shift and I come home and semen is the only bodily fluid that's not on my scrubs. It's just, you know, and it's really sad indictment of my life that the happiest bodily fluid is not part of my working environment. Yeah, okay. Michael's telling me I've got off topic, so I'm just going to go back on topic there. Decision making. So decision making calls for real clarity, because they're really, really important decisions, like the decision, you know, whether you're going to have treatment for a cancer or not, and they're often made in front of us. And we are the first touchstone of medical opinion, and that really matters. That really matters. It's like first impressions matter, and for many patients, that's their first impression of what their next 4 or 5 years are going to be. So being very clear and concise. The other thing that I think is a really hard conversation is the dodgy sell. It's what I call the dodgy sell. But you know what I'm talking about. This is the undifferentiated patient who has pain everywhere, you know, but they have got some abnormal vitals, they've got some abnormal blood tests. I've got no idea, you know, this could be encephalitis, this could be hepatitis, this could be cellulitis, it could be some sort of other itis, but I'm yet to diagnose it, and I've got a list of 15 different investigations they need, none of which will come back in the next hour, and I have to choose a team to admit them under. So I scratch my head and close my eyes, and that's the team I'm going to call. And then I try and convince the person on the phone that I know what I'm talking about, when I really probably don't. All I know is I can't send this person home. And Breaking Bad News and the Dodgy Sell have elements of both the decision making. So the types of communication that you use in both of those are very, very similar. As a senior clinician, I think we actually have our own ways of dealing with all of those different episodes of discussions with patients and with relatives. But what's really hard is when these go bad. And that's what I'm going to talk about more so today. And I think that's actually the hardest conversation, is trying to bring things back to normality, to de-escalate and to get a positive resolution. So I'm going to play you an example now. Can we play the video in a second of when things go bad? And then after that, Michael's kindly going to try and bring things back to normality. And then we're going to critique Michael's efforts. Okay, so we're going to roll the tape.
Hi, are you Mrs. Joffey?
Yeah, I'm Troy.
Okay, Troy, I'm Dr. Reynolds. Sit down.
How is she?
Well, she's had a collapse, as you probably know.
Yeah, I was there. It was terrifying. You know, she was making a cup of coffee one moment, and the next moment she's on the ground. We called her ambulance. They took forever.
Yeah, it seemed a long time.
Yeah, it was a long time. So can I see her?
Yeah, of course, you can see her in a second. I just thought we might have a chat about what would be best sort of treatment we can do for her at this stage.
Right.
When she got to us, she was deeply unconscious, and so I had to put her on a ventilator and get a CAT scan, and not surprisingly it showed she had a massive intracerebral bleed. It means a big bleed into the brain. She had a a big bleed that affects all of the right-hand side of the brain like that.
Right, so what, an operation next?
Unfortunately, I don't think she would survive an operation. So I think that on balance, the best thing would be actually to focus on making sure she's not suffering and to keep her comfortable.
Oh, surely there's something you can do.
Well, at her age, with that sort of bleed, she's not going to survive, I don't reckon, an operation.
At her age? At her age?
Well, I think we should...
She's only 76.
No, well, we're going to keep her comfortable.
It might be expedient for you to keep it comfortable. Okay, so that's bad. We've sort of escalated in a very short pace of time. And now we're just going to do a little role play. So this is the pantomime part of the show. And then hopefully you can all help debrief Michael and myself. So if you sit there, can you hear us? Yep. Well, it might be expedient for you to keep her comfortable. What are you going to do to save her?
Hello,
Yeah.
Michael.
Yeah, I know. You just introduced yourself.
Take a seat.
No, I don't want to sit down. I want you to get out there and save my mother. What are you doing? You're going to let her die?
Take a seat.
I don't want you to see. I don't want to take a seat. This is meant to be a hospital. You're meant to be a doctor. Go save her or move her to a hospital that can. This is a joke of a place. I come in here to get some help. You tell me you're going to kill my mother. She's alive now. Why aren't you helping her?
We're here to work together on this. Please sit down.
We're not here to help work together. I don't want to work with you. I want you to work with my mother.
So we're in this together. We have a terrible situation. You and I have to work our way through it.
No, mate. You need to get fix my mother or move her to a facility that can, because this is just a friggin' joke. You know, she collapses just an hour ago. Now you're here telling me she's going to die. Surely there must be something we can do.
There are lots of things we can do.
All right, we'll do them.
Let's talk about it.
Let's do them.
So,
I don't want to talk. Let's do them.
what's your understanding of what's happened to her?
You've just told me she's got a big bleed in her head. Well, let's take it out, or let's move her to somewhere that can take her out. If you can't take it out here, then there are plenty other hospitals here.
The truth is no one can take it out. There's no treatment. We can't do anything to reverse what's happened to her.
Well, you just told me at her age we shouldn't be doing something, which means that if she was younger, you would be doing something.
I don't think that's what we're saying at all. We're saying when we look at her condition and the terrible events that have occurred with her, we don't have any interventions that are going to help.
That can't be right. You must be something you can do.
So what we have to do together is work our way through it. The question I have for you is, if your mother could see herself in a present situation, what advice would she give if we were to say, if we intubated her, she'd be on a ventilator for weeks and weeks with no meaningful recovery?
I don't know what that means. What's
So
intubate?
what would your mother,
I don't know.
if we were to put her in intensive care?
Yeah, she would want to go to
pregnancy,
intensive care. She would like to get better.
With no-
She'd like to go on with her life.
So we both want her to get better. She will not get better from this bleed.
Well, how do you know?
The brain is gone. Her
I
brain
have
is
no trust in you as a doctor. You've just told me before that you would do something if she was younger. You're just telling me now that there's no chance. I mean, what am I meant to believe?
An old brain is not the same as a young brain. It doesn't recover, it doesn't heal. You'll think about yourself. Your body is not the same as a very young person's body. And what I'd suggest is we get a neurosurgical person to come down and talk to us, and then that'll be reassuring that it's not just one person you're talking to, but the experts across the field.
Well, so you're not the expert, so why am I talking to you? If you could talk to the neurosurgeon, why aren't they here talking to me?
We'll get them here. There's a group of people, it's a team.
I should hope so.
So we need people from intensive care, people from neurosurgery. I'm the emergency medicine specialist. This is a very big decision and we'll take it very seriously.
All right. Okay, we're going to stop there. Big hand for Michael. I'm just going to jump out of character now. I told you, it's kind of like pantomime. In fact, Thanks, Michael. You can sit down. So I just want to ask, what do you think are the things that Michael did that worked well? He remained calm, so his tone of voice. He had great eye-to-eye contact. Yep. Well, he did at the end, didn't he? Well, what do you think about... Because initially he stood up, and Michael's a big guy, and, you know, when I stand next to Michael, I always feel a bit intimidated, but that height differential can be really intimidating, and particularly for a male I'm already in a heightened setting and I'm already agitated and aggressive, that's going to make me more agitated and aggressive because it feels intimidating. So that's, you know, one thing to consider as to whether you should stand or whether you should sit. A lot of people feel uncomfortable sitting when someone's standing and yelling. And I think we need to think about our safety and understand the room dynamics and where the door is and where my alarm buzzer is, and make sure that I know that I'm going to be safe before I do that. But that's a really good thing to do, is to stay seated and allow them to rage around you. Anything else that Michael did that was good? Honesty, yeah. So I think it's honesty and clarity, because the hard thing to do is impart information when people are raging. Because when you're really, really angry, if you think back to times that you've been really, really angry, or when I watch my 11-year-old and he's really, really angry, and he's completely illogical in that he can't understand any argument until he calms down. And that's true of all of us, is that when we're in that rage, you know, sympathetic storm type setting, you can't take in any information. So you need to calm them down first. And Michael did a good job of that, didn't he? Because I was really quite heightened, and then because of his tone, he sat down, his eye contact, he brought it down. He didn't completely calm me down, but he calmed me down to a point where he was able to impart information and we could progress. If you can't get them to that position, then you can't progress. Anything else that worked well? Yeah, that was interesting, wasn't it? So that can be something that works well and something that could actually work against you. And it kind of did initially, in terms of, initially you're saying, well, I'm the decision maker, I've made the decision, we're not going to do anything. And then you're saying, well, there's a series of other decision makers that also have input. And that becomes really confusing. And confusion breeds anger. So bringing those other decision makers in is really important, but I think covering your bases first before you have the discussion. And that goes back to information, someone said it over there, information with clarity and honesty. So putting all your cards on the table. So don't go in with just half a deck. Make sure you go in with the whole deck. What are the things that Michael did that perhaps didn't work as well? I agree, but I think we be a little bit cautious with using, we can do lots of stuff before they calm down, because when you introduce that and they're angry because you're not doing anything, it can become really confusing. And once again, confusion will breed anger, distrust, and that makes it even harder to come back. Yep. But once they've calmed down, then you can introduce those palliative care topics, because there's a lot to talk about here, isn't there? There's, first of all, the decision that we're making that there is no active therapy that can be curative, but there is lots of other things we can do that will be really beneficial for your mother. And one of the things that I've realised doing this and working in practice is giving someone a good death and having the family around with a good death is actually one of the most rewarding things you can do. And we often save people and we intubate them and they go up to intensive care and you never see them again. Or, I mean, I remember once a guy came into Vinnie's when I was a registrar who'd been stabbed in the heart, and we cut open his chest and pulled out this clot and blood's pissing everywhere, and the cardiothoracic surgeon came down and sewed him up and he survived. And I went up to see him about 5 days later, thinking, wow, I'm pretty good. And he was a complete prick. You know, after 5 minutes in a room with him, I wanted to stab him in the heart. Whereas the gratitude from families of having a doctor that cares about their dying relative, that is the value of that is incalculable. It's really, really beneficial. And I think this conversation, which is a conversation we have that every other specialty is afraid to have. You know, I see it time and time again where people come in and they go, "You mean she's going to die?" And yes, you know, she's got metastases all over and she's in advanced renal failure and she's got an ejection fraction of 2, and none of her other specialists have said she was going to die. And this is a conversation we are forced to have at the coalface when people are at their worst. So if we can do this well, we are benefiting more people than just our patient. We're benefiting families and communities. Okay, so we've travelled around with lots of asides, but I guess my point is this, actually. This is my take on the difficult conversation, and you can sort of boil it down into 4 different approaches, and we all, I think, do different versions of these approaches, and you'll take a little bit of this and a little bit of that. So the first one is information with empathy, and I think Michael actually demonstrated that really well, which was empathy to calm them down and then the provision of information. And that's actually my favourite approach too. Meeting aggression with aggression, and sometimes you have to do that. To be honest, you know, in 25 years of working in ED, I've had 2 people escorted out of the emergency department. So it's something that happens really quite rarely, even though we see aggression on a daily basis. But an understanding around that aggression is born out of, you know, frustration and anxiety and fear and all of the other things. So if you calm them down, usually they're not aggressive anymore, and usually they end up being really, really appreciative. Distraction's another thing that we didn't demonstrate, but you know, the offer to look, we're working hard for your mother. Do you want to come and see her? Because that's a nice distraction. Or, look, I understand this is difficult for you. It's going to take some time to work through the number of issues. We've got a number of tests that we're waiting back. Can we get anything for you in the meantime? And having a support person to stay with them. I know that's not always available, but that is very useful and a useful tool. Now, just beware with distraction. That's a temporising measure. It's a temporising measure until you get all the cards, and then you have to go back to information with empathy. Because if you just distract and delay and delay and delay, inevitably you'll get aggression again. And the 4th is what we call, Alan and I have termed the Gandhi approach, which actually Michael demonstrated to some extent, which was just letting them rage. You know, let the tempest wash over you and you just sit there meekly and let them vent and vent and vent, and then they eventually blow themselves out. That can be dangerous. It's really, really difficult to do. I think if you have a bigger frame, such as Michael, it's easier to do. For smaller people like me, it can become quite intimidating. And it also depends on your personality whether you can pull that off. Some people do it really, really well. Others find it difficult. I think the key here, though, is knowing which one of these tools you fall back on, and understanding that there are other tools that you can use, and not each tool is applicable in every situation. So different situations will need different combinations of those tools. And that will be trial and error and based on your personality. I think we're almost out of time. So I'm going to end it there. Oh, actually, so this is an interesting picture. Who knows what this picture is? Have a guess. A tattoo on an arm outside a car travelling at 80 kilometres an hour. That comes from the very imaginative mind of John Mackenzie. Yeah. Anything else? This is actually a picture from the Viking spacecraft of the surface of Mars. And I put that up there because, just to illustrate that without context, often you can't make sense of what you're seeing. And that's true of our patients and our relatives because they don't have the context that we do. So it's our job to provide that context so they can make sense of the picture we put in front of them. All right, I'm going to end it there. Thank you.